cardiology at Tanta University and a member of Heartbeat team and fellow of Prof. Mervat. Today, our talk will be about atrial tachycardia. And of course, atrial tachycardia represent about 10% of SVT cases, carrying significant morbidity and mortality. And with the recent advances in catheter ablation, it's now clear that it's the preferred solution for it over medical treatment. In the past, they used to classify arrhythmias coming from atrial tissues as either atrial flutter or atrial tachycardia. In atrial flutter, they said that the atrium was in a state of continuous activation, and they identified it from the ECG by that the way the P waves are continuous with each others. There is no isoelectric line, and the rate is usually faster. And in the past also, we identified atrial tachycardia as that there's a clear isoelectric line between the P waves and the rate is much slower. However, now this is not accurate, as slowly conducting and protected isthmus and antiarrhythmic drugs and extensive scarring may lead to the appearance of reentrant tachycardia with distinct P waves with isoelectrical line at slower rate. And also, a delayed and slowed atrial conduction due to atrial myopathies and previous ablation in the atrium can lead to a slow and broad atrial activation, mimicking flutter in focal atrial tachycardia. So this is the new classification of atrial tachycardia, and the term atrial flutter is now preferably referred to the typical counterclockwise or the reverse or the clockwise peritricuspid atrial flutter. So the classification is either a non-reentrant atrial tachycardia or reentrant atrial tachycardia. The non-reentrant atrial tachycardia, as we know, is either automatic or triggered activity. This is when we are talking about the mechanism. But from practical point of view, it doesn't differ a lot, as we will see in the next slide. Reentrant atrial tachycardias are two types. The type that is called a macro-reentrant atrial tachycardia, in which the reentry takes more than 2 centimeters, and there is a large area like a perimitral reentry or peritricuspid reentry. And the localized reentry is either micro reentry, which is in the level of the cells, and when we map it, it looks like a focal pattern of activation with centrifugal pattern versus small circuit reentry, which is related to a small scar, and there is a reentry around it related to previous ablation or previous surgery. So, in summary, atrial tachycardia is either focal, which give you this pattern, a centrifugal pattern, and a reentrant, which give you the pattern of early mid late, and you can see it now. So, non-reentrant atrial tachycardia has two mechanisms: automaticity and triggered activity. Automaticity is mainly related to enhanced phase 4 depolarization, and the slope of phase 4 is increased so that the rate of firing is increased. Usually, it comes in the form of short bursts, and it's usually non-sustained. And if it's sustained, it's usually has a poor response to DC shock and medication. We may try beta blocker, calcium channel blocker, class 1 like flecainide, and class 3 antiarrhythmic, and even ivabradine is prescribed in such cases, but the response is usually poor. Adenosine may lead to transient termination and reinitiation, or may have no effect at all. When we are trying to map these forms, those forms are usually not inducible by pacing. Solutions for such big problem is induction by isoprene, and also IV calcium is prescribed in such cases. If we try to perform in treatment, you almost never get a PPI like the cardiac cycle length, but as you get closer to the focus, and if you perform pacing, you will get a shorter PPI. Also, the signal of ablation is usually have a discrete and sharp signal, not a fractionated signal usually. The triggered activity form, the mechanism is related to early or delayed after polarization, mainly related to phase 2 or phase 3 of the action potential. IV adenosine may terminate it. Also, DC shock and IV medication may affect it. Induction is usually by programmed stimulation, not by IV medications. Calcium also may be efficient in such cases. If you entrain at the exact site of this tachycardia, you will get a short BBI. So these are uh, academic methods to differentiate the triggered activity from the automatic origin of the non-reentrant atrial tachycardia. But this is not for a practical point of view, and also the ablation may show small, short fractionation. The reentrant type, this is the important one and the one that led to the development of the last paper published in ERA. The macro reentry, which is related to entry more than 2 centimeters, and the small reentrant atrial tachycardia, and in which the reentry is around an atrial substrate, usually a scar or a functional obstacle, and usually less than 2 centimeters, and the micro reentrant form. The micro reentrant is manifest like the non-reentrant ones, and it gives a centrifugal pattern of activation, but it's usually inducible by pacing, and at a certain point you will get a long fractionation, and it's usually ablated by focal ablation, not linear ablation, and it may be terminated by DC shock or IV medication. And if you uh, perform entrainment at the site of ablation, you may get BBI equal to cardiac cyclins, but you will never get an intracardiac fusion during entrainment. So the most important thing in the new paper is the localized reentrant atrial tachycardia. Uh, these ones are related to previous ablation and previous surgery, and may be related to a small scar or incomplete WACA. If you perform a conventional mapping, you may see it like a centrifugal pattern of activation, and you just ablated by one point. And when you are at the hot point, you will usually find a long and fractionated signal. And this fractionated signal, usually more than 30%, and mostly more than 50% of the AA interval, which is the tachycardia cycle length. And you at the hot point, and if you ablate at that hot point, you will terminate the tachycardia, but the tachycardia will clear. So this is the rule of high density mapping. Such case, when you suspect a localized reentrant atrial tachycardia, you have to perform a high density mapping. And if you confirm the diagnosis, you will have to perform a linear ablation, even if you terminated the tachycardia. And that's why they are usually in the anterior left atrium and the related to left atrial appendage and the interatrial septum. These are the sites of AF ablation. Form is always related to previous AF ablation surgery. If you found the re-entry related to the vein of Marshall, you may instill ethanol in the vein of Marshall. And if it's related to the left atrial appendage, you can ablate this type by focal ablation, not linear ablation, because of the risk of isolating the appendage, and in the literature, it's prescribed to be successful. So this is a short summary how to differentiate between different mechanisms of atrial tachycardia. And you can see that in micro reentrant atrial tachycardia, you don't need a substrate, but in the small reentrant atrial tachycardia and the macro reentrant, there must be always a substrate. And induction by pacing is in all form except for the non-reentrant atrial tachycardia. And the local signal is not fractionated in automatic tachycardias. There is just local fractionation in the micro reentrant tachycardia. You get fractionation at multiple points in the macro reentrant atrial tachycardia, and you get a fractionation at the hot point more than 50% of the tachycardia cycle length at the small reentrant atrial tachycardia. Are you hearing me well? Is my voice clear till now? دكتور ميرفت؟
Yes, Dr. Ahmed.
ايوه yes
Okay. Okay. So we will continue to the practical part of the lecture. What is the workup needed for patients with atrial tachycardia before EB study? Basically, you need a 12-lead ECG of the tachycardia. You need to perform echocardiography and Holter. And when you are performing ECG analysis, you have to start from the basic thing to the most advanced thing. First, is it atrial fibrillation or atrial tachycardia or atrial flutter? How to differentiate between coarse AFib and atrial tachycardia? You have two things to look for. First, you check for the B wave morphology. Is it constant in all beats or not? And also, you can measure the BB interval on the surface ECG. If it's a reentrant atrial tachycardia, the variation cycle length should be less than 20 milliseconds. Never count on V1. A lot of people diagnose atrial flutter from V1. In cases of AFib, of course, AFib, the right atrial activation may be much more organized than the left atrium. And when you look at V1, you are mainly seeing the right atrial activation. So it may mimic flutter. So the paper recommends that you never count on V1 for differentiating between atrial fibrillation and atrial tachycardia. And if you want to see the P wave more, you can give adenosine or perform vagal maneuvers, but the adenosine may trigger AFib. Also, the excessive vagal stimulation may trigger AFib. You can also increase the gain, and you can perform, we call it lead, and here is an illustration how to connect it by connecting atrial or sinus. This may be challenging. Look here, tachycardia, and here is the sinus rhythm, and here is a beat of tachycardia. Look how they may resemble each other, although this one is coming from the right superior pulmonary vein and this one is related to crista. So if a patient is coming to you and in persistent tachycardia, how would you differentiate in appropriate sinus tachycardia from atrial tachycardia? The best thing is that you perform an exercise test. In sinus tachycardia, the atrial rate will be variable and the PR interval usually shortens and B wave gets more peaked in an appropriate sinus tachycardia. However, in atrial tachycardia, the rate is usually fixed and the PR interval prolongs. So the last thing you can get it from the ECG is that you localize the source of the tachycardia. Focal atrial tachycardia usually occurs at certain places. They can occur from the right atrium in 33% of cases, or the left atrium in 30% of cases, or paraseptal in 37% of cases. And of course, the most common site from the right atrium is the crista terminalis. Then you can get tachycardia from the tricuspid annulus, right atrial appendage. Also, you may get it from the coronary sinus ostium or the coronary sinus body. And of course, from the right side of the septum. Paraseptal atrial tachycardia refers to the perinudal area and the left side of the septum. And of course, the left atrium, you may get it from all the pulmonary veins, left side of the septum, and the superior mitral annulus. So then you look at P wave in 1 and AVL. If you get a positive B wave in V1, this can, with a very good sensitivity, predict a left atrial origin versus crista terminalis origin. So positive B wave in V1, almost always left side atrial tachycardia, and sometimes maybe crista terminalis. Negative B wave in V1 is usually right side atrial tachycardia. If it's positive then negative, it's usually originating from the crista terminalis. If it's negative then positive, it's usually a paraseptal focus. Then you look at lead 1 and AVL. If they are negative, these quite reliably predict a left atrial origin with high sensitivity. Okay? But these rules do not work with the structurally abnormal heart, especially in the presence of a scar or antiarrhythmic drugs and severe atrial myopathy, because there may be areas of slowed conduction and areas of scarring, and so you can apply these rules in structural normal heart. And this is the algorithm for localization. If you get negative in V1, this is mostly coming from the right atrium. You look at V2 to V4. If they are positive, they may be crista. If they are negative, this is a more anterior structure. You look at the inferior leads. If they are negative, so it's the activation of the atrium is coming from below upwards. It is from the inferior aspect of the tricuspid annulus. If they are positive, it's coming from the superior aspect of the tricuspid annulus, or adjacent to it, you can get the right atrial appendage. A positive negative is almost always crista. A negative positive or isoelectric positive, you look at AVL. If AVL is negative, this is a left side structure, which is the superior mitral annulus. If it's positive, it is septal or paraseptal atrial tachycardia or coronary sinus ostia. Isoelectric is mostly right side of the septum or perinodal. Positive, it's a left side atrial tachycardia. So you look at lead 2 and V1. Just look at the B wave. If the B wave is broad and bifid and wide, so this is a structure in the lateral side of the left atrium, which is the left-sided pulmonary veins and the left atrial appendage. And if they are not bifid, you look at the sinus B wave. If it's positive negative, you're usually talking about right side pulmonary veins or crista terminalis. And here is an ECG example. This is for the localization of the left atrial tachycardia. Look at V1, all are almost positive. Then look at the B wave here. It's broad and notched because these are the left-sided pulmonary veins. Unlike here, they are narrower because the right-side pulmonary veins are related to the center of the heart, so they give you a narrower P wave. And if you look at the inferior leads, you can see that the inferior veins may produce an isoelectric or slightly negative P wave in the inferior leads and positive in the superior veins. The mitral annulus, you get a V1 that is negative then positive. AVL and lead 1 are negative. CS body, you can see it's also isoelectric positive or negative positive, but AVL is positive. So that's how to differentiate mitral annulus from CS body, and you can see that the left atrial appendage, you get a positive P wave in V1 and a broad and notched P wave in lead 2 and V1 also. And look, also the inferior leads are positive because they are superior. The right side atrial tachycardia, you look at V1, you can see that it's positive negative in crista terminalis. And of course, if it's a high crista, you will get a positive P wave in the inferior leads. If it's low crista, you may get it slightly negative in the inferior leads. The tricuspid annulus gives you negative P wave from V1 to beyond V4. And if you look at the inferior leads here, they are negative, so that it's a lower tricuspid annulus origin. And this one is also important. If you look at V1, you can see it's negative positive. And if you look at AVL, it's positive. So this is related to the coronary sinus. So the first part, when you are facing a patient with atrial tachycardia, is that you examine the ECG pretty well and you try to localize the source of the atrial tachycardia before you getting the patient on the table. Then there is a pre-procedural consideration. First, would you put the patient on general anesthesia or not? Also, anesthesia may help you with the stability and reduce the risk of map shift, but it will reduce the inducibility. So always remember that least is the best for regarding sedation and anesthesia. It's better to perform these procedures while patient is awake. Then if you needed to perform an extensive ablation like isolation of a certain pulmonary vein, you may induce general anesthesia then. Always monitor fluid intake in patient with atrial tachycardia because you got irrigated castor and irrigated chassis. Better to use ultrasound guided puncture. If you are in the left side, keep the ST over 300. Induction, of course, by basing if it's reentrant or triggered activity, and by isoprenaline, IV calcium if it's automatic tachycardia. You should also counsel the patient about the risk of recurrence, which we'll talk about in the next slide, and check that the patient has already stopped his medication at least 5 half-lives before the procedure. Uh, Atrial tachycardia with automatic origin has a strong neural control, especially for ones coming from the pulmonary veins. Some types of atrial tachycardia, like speech-related or breathing-related or degradation-related, are affected by the neural control of the ganglionic plexi, which affects the atrial refractory period and the action potential. And interventions to induce atrial tachycardia would be isoprenaline. Sometimes atropine may induce atrial tachycardia, so keep it in mind in difficult cases. Some physiological maneuvers also like isometric hand grip, hyperventilation, and inhalation of a pure oxygen also may induce atrial tachycardia with suspected neural control. And uh, here is the risk of recurrence for the patient. Those with structural normal heart, of course, and no previous surgery nor ablation will have the lowest risk, and those with structural abnormal heart and macro reentrant or multifocal origin will have the highest risk of recurrence. However, always remember that the patient with the worst profile are the patient with the best benefit. So this consensus recommended atrial tachycardia ablation in patients with complex structural heart disease to reduce heart failure. Ablation is preferred to antiarrhythmic drugs in patients with pulmonary hypertension, and it's preferred in patients with amyloidosis. So in patients that you are afraid of recurrence, counsel the patient and give the patient his chance. So this is a simplified strategy. First, you have to examine the ECG very well. You insert 3 venous sheaths, a decapolar caster or a halo caster to the coronary sinus and quadripolar caster to the RV, then to the right atrium, and perform EP study. And in the EP study, you have to induce atrial tachycardia first, exclude supraventricular tachycardia, and localize the origin of the atrial tachycardia from the ECG and from the coronary sinus caster. Then you start mapping and identify the precise mechanism. Is it focal or re-entry? Then you perform ablation, and almost in most of the cases, you should use long sheaths. So electrophysiological study may mainly include ventricular overdrive pacing, atrial overdrive pacing, and entrainment. Ventricular overdrive pacing is the most performed maneuver for differentiating atrial tachycardia from the SVT. And when you perform ventricular overdrive pacing, as illustrated in the previous lectures, you have to check for 4 things. First, are you capturing the ventricle? Then, is there a VA conduction? And if you have a VA dissociation, this excludes AVRT, but not necessarily excludes AVNRT. And are the return tachycardia have a regular cycle length? And you have to identify the last retrogradely conducted A. Then you examine for the PPI and the response, whether it's a VAV response or VAAV response. So in this tachycardia, we performed ventricular overdrive pacing, and we can see that we are capturing the ventricle here, as we can see from the ECG, and we are actually, there is a retrograde one-to-one conduction, and the atrial cycle length is resembling the ventricular cycle length, about 410. Then the tachycardia resumes. And clearly we are having, this is the last retrogradely conducted A wave, and this is the first A wave in the tachycardia. And clearly we are having a long PPI and a VA-AV response. This should be differentiated from the pseudo VA-AV response, which occurs most commonly with atypical AV-NRT. When there is a long VA time, and this one, the VV interval is 470, and here the AA interval is 470. So this one conducts to this one, and this one conducts to this one. And then there is a VA response. So it's actually a VAV response, but it gives you the pattern of the pseudo VAAV response. So you have, that's why you have to measure it very precisely. Then the second maneuver is that you check for the AA and VV relation. If the AA, like in this one, is driving the VV, you can say that it's atrial tachycardia. You can see here the atrial rate is slow, so the ventricular rate slowed. Then the atrial rate accelerated, and then the ventricular rate accelerated. So the atrium drives the ventricle, so this is atrial tachycardia. If the reverse, it's either AVNRT or AVRT. Then there is atrial overdrive basing to demonstrate VA linking. So when we are studying atrial tachycardia, we try to avoid atrial basing, but in tough cases in which you cannot differentiate between atrial tachycardia and AVNRT, this may be the solution. But always remember that when you are performing atrial basing, you should be less than 20 milliseconds faster than the tachycardia cycle length, and you study the first return VA time, and you correlate it to the rest of the tachycardia VA time. If they are the same, there is a VA linking. So the A is depending on the previous V. So this is AVNRT or AVRT. If this response, if the VA time is variable, this is atrial tachycardia. Okay, entrainment. Entrainment. The first question is, should we entrain it, the tachycardia, or not? The problem with entrainment is that you may, when you are trying to perform entrainment, you may stop the tachycardia, and you may get nightmares while you are trying to induce it again. So always remember that entrainment has a lot of advantage, but you may spare it as a last solution. So entrainment in atrial tachycardia, what is it? What is the role of entrainment? First, if you do entrainment and you got a BPI minus tachycardia cycle length over 3 milliseconds, you are outside the loop of the re-entry. If you perform entrainment and the BPI is less than minus tachycardia cycle length less than 30 milliseconds, so you are either within active loop, and if you terminated without global propagation, you are mostly within the critical isthmus. And then you can perform entrainment from multiple sites. And if the distance between those two sites is more than 2 centimeters, this is a macro-entrant atrial tachycardia. So the first rule is to differentiate macro-entrant atrial tachycardia from localized re-entrant atrial tachycardia. Then by entrainment, you can differentiate re-entrant from non-re-entrant atrial tachycardia by performing entrainment at different basing cycle lengths, like entrainment faster than the tachycardia cycle length by 10 milliseconds, then by 20 milliseconds, then by 30 milliseconds. If the BPI is stable, this is a re-entry. If the BPI is variable, this is not a re-entry. And always remember that when you are performing entrainment, even in non-reentrant atrial tachycardia, whenever it gets shorter, you are getting closer to the origin. Okay. Then what is the role of our caster, and how can we maximize the benefit of our casters in the EB study? First, the coronary sinus caster, which is a very important caster because it works as a stable reference. Some operators before may suture it to the skin to make sure that it's stable. And the coronary sinus caster gives you mostly a clear and sharp A and a humpy and small V. So you can take it as a good reference because you won't annotate the V, but always check for fractionation because if you are in a tributary or there is abnormal musculature of the coronary sinus, you may get a fractionated V. Then you check for the pattern of activation, which can help you in identifying the clinical tachycardia from the should it in reference. Actually, the pattern of activation of the coronary sinus can be useful in the left-sided atrial tachycardia localization. So if you are having a distal to proximal activation, this is a very sensitive to left-sided atrial tachycardia. But if you are having proximal to distal, this is not necessarily a right-side atrial tachycardia because it may be a left-side atrial tachycardia with septal to lateral activation. So you may then place a quadripolar caster in the lateral right atrium and check if the lateral right atrium is preceding the the proximal CS. Hence, you will start with mapping of the right atrium, or if it's not, you may start with mapping of the left atrium or the septum. And there is the chevron or reverse chevron CS activation pattern, which is like this. You can see the CS here and 910 here. This inverted V-like shape, and it's in this case like in and this actually from posterior wall and activate the mid CS first, then to activate the distal and the proximal CS. So whenever you see this pattern, you have to search for tachycardia coming from the wall of the left atrium or roof-related reentry. And if you are having this pattern in which this is atrial tachycardia coming from the anterior wall of the left atrium, and as we can see it, it comes to the anterior mitral annulus and it converges to the mid CS. So the distal and the proximal CS will be activated first. Then what is the role of electroanatomical mapping? It is made advisable to reduce fluoroscopy and radiation exposure. Also, it gives you better understanding of the anatomy, and the system annotates the local activation time by detecting the steepest negative deflection at both the unipolar and bipolar electrograms. And when you are using multipolar caster, you get a smaller electrodes with narrower inter-electrode spacing, giving you a better mapping resolution and the clearer and less fragmented electrograms. So this is the advantage of the high density mapping, is that with the high density mapping, you can differentiate between focal atrial tachycardias and non-reentrant atrial tachycardia and the small reentrant atrial tachycardia. Because with new casters like the HD grid, you got the omnipolar technology, which protects you from the cancellation effects related to the bipolar blindness. And also, more electrograms give you better anatomy and better understanding of the anatomy and give you faster activation mapping. And in some algorithms like parallel mapping in CARTO, you may perform simultaneous mapping for multifocal atrial tachycardia. Voltage mapping is not very important, except if you are suspecting small reentrant atrial tachycardia. but there is a problem that we do not have a standard thresholds for scar in the atrium. So you may need, if you are suspecting that there is a scar, you may to customize the bipolar voltage. Ablation, it's almost always recommended to use irrigated tip catheter, preferably with contact force sensing. If you are afraid of injuring the phrenic nerve, you may use focal PFA. Parahesian sites may be ablated with cryoablation. Focal ablation for non-reentrant atrial tachycardia and micro-reentrant atrial tachycardia at the site of the earliest atrial activation with the QS pattern. Linear ablation for small reentrant atrial tachycardia. So always remember that you have during the EP study to differentiate between small reentrant atrial tachycardia and non-reentrant atrial tachycardia. And the endpoints are non-inducibility, of course, and termination of the tachycardia by ablation, not by BAC. And here's precautions when you are ablating at certain sites. So when you are ablating at cresta terminalis, you have the phrenic nerve in close proximity, so you have to perform basing at the hottest point before you ablate, so that you check that you do not capture the phrenic nerve, and if it's possible, you try to identify the SA node if you are suspecting that you are close to it by activation mapping during sinus rhythm, and always remember that crest terminalis is the most common site. If you are having a parahesian atrial tachycardia and you have mapped the right atrium pretty well, and you got the earliest activation at the septum, before ablating at the HIS, you have to perform transeptal puncture and map the left side of the septum. Then you should map non-coronary cusp. And if you have to ablate, you start first by ablation at the non-coronary cusp because it's much more safe than ablating at the parahesian region. And of course, if you are having cryoablation, focal cryoablation, it will be very useful in such cases. Pulmonary vein atrial tachycardia, always remember that the best solution for them is to perform antral isolation, not ostial isolation, because the tissue contributing to atrial tachycardia usually is located at the antrum. So whenever you are having an atrial tachycardia coming from the pulmonary veins, perform antral isolation of the target vein, of course, not bilateral wacca, of course. SVC is you may encounter atrial tachycardia coming from the SVC, and usually isolation gives better results than focal ablation, but you have the problem of SVC stenosis, and always remember that the left resistant SVC may function as a source of focal atrial tachycardia or even reentrant atrial tachycardia. Left atrial appendage. Left atrial appendage is the one with the highest risk. You should never isolate it because isolation of the left atrial appendage increases morbidity and mortality in the studies. And in rare cases, surgical resection is prescribed in some case reports, but focal ablation usually works pretty well. And when you are trying to map the appendage and you have to choose a catheter, circular mapping catheter improve stability because they rest in the walls of the appendage. Tricuspid annulus use deflectable sheaths, and this is a workflow for atrial tachycardia mapping. First, you have to analyze the 12-lead ECG, then you perform activation mapping and analyze it, and study the propagation pretty well, and differentiate whether it's reentrant or non-reentrant atrial tachycardia. Then you perform advanced EGM analysis and study whether the signal is fractionated and prolonged or not, and the activation pattern of the coronary sinus. And if you still cannot differentiate, you may perform targeted entrainment and identify the type of the tachycardia. Ablation workflow for non-reentrant atrial tachycardia ablate at the early site. For locally reentrant atrial tachycardia, ablate the hot point with the fractionated potential more than 50% of the tachycardia cycle length and perform linear ablation to reduce the recurrence rate. And for the macroentrant atrial tachycardia, this would be the talk of the next lectures. So this was actually a case of incessant atrial tachycardia in a 25-year-old girl. And when we look at the ECG, we weren't sure is it atrial flutter or atrial tachycardia. So you got two B waves, and the two B waves are very close to each other. So this works was flutter according to the old classification. And when you localize it, it seems to be coming from the left side because the B wave is positive in V1. And it's not typical flutter because the inferior B waves are positive. And here is the CS activation. You can see it's coming from proximal to distal, which is the least specific pattern. So we mapped the right atrium and we couldn't get good point or map most of the cardiac cycle lengths. Then we perform a transeptal puncture, and here is the activation. As you can see, we have mapped the left atrium, the right atrium, and the left atrium, and the hold point is related to the left inferior pulmonary vein. And here is the activation map. And here is the voltage map. As you can see, that the atrium is clear, and there is a small scar here. And if we return to the ECG, if we look at the map, the activation pattern seems to be focal. It's coming in a centrifugal pattern. So, and if you look at the ECG, you got the P wave positive in V1, so that this goes with left side tachycardia, left side atrial tachycardia, and the P wave is notched and broad. This comes with, this goes with left side pulmonary veins or left atrial appendage. Here is the propagation. It's coming in a centrifugal pattern, and here is the ablation point. As you can see, when we performed isolation of the left inferior pulmonary vein, and actually the hottest point got this recording. Can you see how much is it fractionated? And it's taking almost about 100 milliseconds, near to 40% of the AA interval. And as soon as you start ablation here, you stop the tachycardia. So according to the previous information, this type is mostly related to micro reentry or localized reentry, and so that it stopped here with ablation. Here is the ablation. As we can see that the tachycardia is running and start to get a good contact at the hottest point, and with just as we start ablation, the tachycardia stopped. However, we performed isolation of the vein. Thank you very much.
Thank you very much, Dr. Ahmad Rossasy. الحقيقة this is really a very intense, very educational lecture, and I did technical benefit out of it. I know that the candidates are